Okay, well, a very excited day today. We're very excited to get to talk to everyone today about the evolution and treatment of lung nodules and lung cancer here specifically at UT Southwestern. We have an excellent panel to introduce. Today we have speakers from Dr. Interpol Sakaria, who's a thoracic surgeon here at UT Southwestern, Dr. Kenneth Westover, who's one of our radiation oncologists here at UT Southwestern, Sheena Bala, who's one of our physicians in the Department of Internal Medicine, and lastly, but not least, Stephen Wu, Dr. Wu, who's an interventional pulmonologist here at UT Southwestern. But first off, my name is Curran Eichelberger. I just wanted to give a really brief overview about access and really our intake process here at UT Southwestern and how we get patients in quickly to advance our treatments and to really grow our access here across UT Southwestern. First off, really, we just wanted to give a brief update about who we are at UT Southwestern. So we have really three main pillars around education, discovery, and healing of many of our trainees, patients, and research scientists we support across many of our campuses. You can see listed throughout our system. So just when you come to UT Southwestern, you're going to get a lot of great care and great team members to support your treatment across our campuses. But let's dive into lung cancer and specifically why we believe we're offering some very great programs. And I did fail to mention all of this information will be sent in the next couple days, and this is being recorded. We want this to be Q&A, and we're not offering any personal medical advice, but really information to help inform each of our patients across the journey for potential lung cancer. But you can see here we're very proud of a lot of the great work and team members who've supported specifically our U.S. News and World rankings. These are rankings where we put a lot of investment into, a lot of pathway and patient outcomes that we try to really drive for success. And you can see here we are ranked in the top 20 across the nation for both cancer and pulmonology and lung surgery, which we'll get more into throughout this presentation. But I really just wanted to show the great work that our team members across UT Southwestern have put in to make this happen. A little bit about the complexity of lung cancer and why the pathway can be complex and challenging to navigate. This is an example. This is not a UT Southwestern pathway, but you can see here there's many different avenues of how discovery of lung cancer can be discovered. This could be through a low-dose CT, potentially an incidental finding. You might show up in the emergency room or have an X-ray or some sort of image with your provider, and there could be a potential lung nodule or discovery. What we are trying to combat here is this 14 to 18 weeks time to treatment. As we know, that is just a lot of time and something that is a major risk factor in this population. So on our next slide, you'll see what we're doing here at UT Southwestern to really combat that and get that time to treatment down to hopefully within 2 weeks. And just as I mentioned, we are actively trying to streamline this pathway for patients to come into UT Southwestern, get connected to a care coordinator, get connected with a physician, an APP, an expert in our field to really drive patients to where they need to be treated and potentially the best intervention or care or pathway for them to meet their needs. You can see down here, we're trying to get that within 14 days. That would set us up as one of the fastest treatment plans across the nation. And this is what our patients deserve and something we're actively focusing on, moving the needle, not only in DFW, but really across the nation. And I think one thing just to mention here, this is a multidisciplinary team with our surgeons, our oncologists, our medicine specialists to support this process within our cancer center. This is just a little bit of a brief example of some of the treatment plans that our thoracic surgery division offers here. And what we're seeing is a robust group led by Dr. Sakaria, who you'll hear from shortly, and really some of the treatment options that we offer and the robust and multidisciplinary care that is offered here at UT Southwestern. And what we're trying to do with this care is offer it close to home. Obviously, we have our beautiful facility down here on the main medical district, but we're trying to really expand. We have now facilities in Fort Worth and Richardson, Redbird, which is in southern Dallas, and then also in Capel, and even our partnership with Texas Health Dallas, the Presbyterian Hospital there. So we're trying to bring this care closer to home for our patients to really combat and improve access for lung cancer treatment plans across Dallas. And finally, something that we are very proud of is is we offer a little bit of a different approach than some of our other colleagues. We always are partnering with our RM program coordinator. So this is, think of as a navigator, as a liaison, someone to really partner with our patients across the journey to really help them navigate through these complex and large health systems. If you recall that slide a couple slides ago, it was very complex, lots of decisions, lots of providers involved, but we assign team members to really partner with our patients to help them navigate through this challenging and sometimes a timely process. But we're trying to get that down to 2 weeks, and this is just an example of Jackie, who's one of our coordinators, a part of this program. And my last slide is really, we want to help. We want to be a part of your patient care journey. We want to be partners with you. We want to answer any questions and take care of all of your needs. And please reach out if there's any questions, and happy to take care of anything that we can do to make this care journey much better. And so with that, I will now introduce Dr. Sakaria once again to help really to help us lead through some of the advancements in lung cancer, specifically to thoracic surgery.
Thank you, Karen, for that introduction. And just to, just give a little background here for everybody, all the physicians on this panel are part of a much larger team. Sheena Bala, really one of our medical oncologists who treats so many of our patients, Dr. Westover, Dr. Wu, myself, the 5 other surgeons that are in this group, and the multiple other docs. We get on a multidisciplinary call every single week to talk about these patients and the people that we're trying to get through. And I see a lot of chat going on, but I'm going to go ahead and share my screen here and focus it on just one area. And we're just going to give you sort of highlights of some of the areas that we work on. There's too much to go over in really one area, but if everyone can see that and just confirm, I'm going to go ahead and put this into presentation mode. All right. And we're going to talk a little bit about advanced imaging in thoracic surgery. The interesting challenges that come with cancer of the lung and when we are talking about surgery. 5-year survival is still on the lower side than we would like to see. And we're still diagnosing at a later stage, although this is getting better over time, especially with a lot of the screening methodology. It's hard to get to an ER without getting a CT scan these days, which actually has some upswing and benefit. But recurrence after lung cancer surgery and treatment is still up to 25% of patients, and it can occur back even in the same lung. The average survival is, well, if once you have a recurrence, it's a bad disease. It's a tough disease to overcome. And up to 8 to 9% of patients may have additional lesions, meaning we identify one lung cancer and there may be a second primary or a second metastasis somewhere in that lung that we may not recognize at the time of surgery or sometimes on our preoperative imaging. Margin is very important. What is the margin? The margin is our ability to completely get the cancer out at the time of surgery. And we assess that in different ways, but it's not a perfect science. And we're always looking for ways to do that better. And during minimally invasive operations, we've gone to very small incisions, well away from the traditional way of making large incisions. But the benefit of the large incisions was that we could get our hands into the chest. We could feel tumors. We could really, with a lot of confidence, know exactly what we were going after. We buy a lot of upswing with minimally invasive operations in terms of recovery and less pain, less, say, trauma to our patients. But we are unable to do what we used to do. And we need different technologies to help us identify those tumors in better ways. And what are some of the ways that we can do that? Well, we're going to go over some of that in this talk. But the intraoperative, once we're in surgery, what are some of the challenges there? Because we talked about those higher rates of minimally invasive surgery, we may have difficulty, again, identifying occult metastases or synchronous lesions. What's an occult metastasis? That's one that wasn't recognized on the preoperative imaging as we went in, and we might find it at the time of surgery. And do we have ways that we can better identify those additional tumors that we might not have known about? And localization of even the primary tumor, finding it. Some of the tumors we go after are very subtle. They're in the actual lung itself. We may not see them visually at the time of surgery. We need better ways to know where they are, whether it's with preoperative imaging technologies or way in surgery to help us with other technologies see what the naked eye can't see. And then margin assessment. How can we be really sure that we've got no tumor at the edges of what we've removed? And I think all of that is quite important for us to do better with. Some of the things that we're doing here at UT Southwestern, we've adopted technologies that let us do very sophisticated preoperative imaging of the tumors based on the CT scans we have. CT scans give us tremendous information, but as we move towards Minimally invasive operations that try to remove less lung, what's called a segmentectomy or even a wedge, where we want to spare more lung, as opposed to the traditional type of operation, even for smaller tumors, where we removed an entire lobe of the lung, a much larger area. But we can do that. And you see here, I don't expect everyone to understand what these images are showing, but I'm going to point here to that fourth image from the left that's showing an encirclement of a tumor there in the lung that's giving us a very good preoperative, sophisticated idea based on the CAT scan. Are we going to get a good margin if we do something trying to spare lung? So these types of technologies are helping us tremendously to plan our operations and to do better operations and avoid potentially getting those poor margins. One very interesting area of work that we've been doing is in the area of intraoperative molecular imaging, something I've been personally involved with for a long time and that we are doing here at UT Southwestern. This is using different types of imaging to augment what we cannot see with the naked eye. This particular agent, based on what's called folate, it's something that's found in cancer cells 10,000 times higher than, say, normal cells, is an agent that we can give by the bloodstream just before surgery. It's very safe. It's been used in thousands of patients. This is the first time it's been approved by the FDA for a certain disease in lung cancer. It's the first of its kind for lung cancer. And it goes right to the tumor. It binds to the tumor. It gets internalized by the tumor. And with special cameras at the time of surgery, helps us identify the tumor and those additional tumors that we won't necessarily see. We've done plenty of preclinical studies, meaning before putting this out and having the FDA clear, these are the studies that helped us to identify if this was a viable technology. And this is a very busy slide. We were involved with a lot of the initial investigations, but what this showed is that using this technology in about 26% of cases, it changed the conduct of the surgery, meaning we saw something at the time of the operation we would not have otherwise seen. And this is the third, what we call phase 3 trial, the one that really kind of showed, again, in a broader population across multiple institutions, that there were about 50% of patients that had what were called clinically significant events. And again, in multiple cases, helping us to identify additional tumors, do a better job of identifying the primary tumor, in some of those cases, helping us to improve the margins. We were involved with the first clinical use of this in sort of the broader population, and we really saw nothing surprising, exactly what had been seen in the clinical trials. Clinical trials are very stylized, very regimented, and once in a while, what you see in the real world doesn't represent necessarily what you saw in the trial. The trial is sort of that ideal case use, but what happens when you put that technology into the broader population of surgeons? And we saw exactly the same thing, that we were really starting to see tumors better, identify the primaries, and in many cases see additional tumors. This is what it looks like. And picture's worth 1,000 words. Upper left, that's what we see with white light, the normal traditional imaging. Every one of those other images is augmented imaging based on the molecular marker that's in those tumors, helping us identify the primary tumor. This is lung, doesn't matter so much whether you recognize these images. What you see are those glowing spots. That's an additional tumor that wasn't additionally identified on the preoperative scan. This is looking at the margin. We can see that we're very close to that margin, that we may have to take additional tumor. This is at the time of surgery, and in some cases doing better as what we call frozen section, that traditional way that we look at these margins. So very compelling technology that we think is really helping us do a better job at the time of surgery. The characteristics, this is just another look saying that we saw not only the primary tumor, but many different types of tumors, including metastatic lesions. The lung is a, unfortunately, favorite place for many cancers to travel to, and these types of technologies help us identify several different types of tumors. This is what we call occult lesions, as you see the title here. Again, that same picture with the one encircled by the clamp is the primary tumor. The other was another tumor that would have potentially been missed had we not seen it with this technology. We've been using it here now at UT Southwestern for quite some time, and these are specific cases that were done here. This is a patient of ours that had what's called a ground glass opacity. Not so important what that means, but it's a very subtle lesion in the lung that can be very hard to feel and find. And even on a CAT scan, it's a very subtle area that traditionally we used to mistake for areas of small pneumonia. And there it is, lighting up. Very difficult to identify with the white light, but lighting up very well for us to make sure we're getting that right area, getting that out completely. This is an additional tumor. This is what they call a GGO that was deeper in the parenchyma, and a secondary nodule, that bottom left panel, very subtle there, but identified with this technology, a separate area of tumor that really even on the preoperative scan was very subtle. And whether you saw it on the preoperative scan or not, if you don't recognize it at the time of surgery, you can't take it out. So are we doing a better job now at getting these early stage lung cancers out? And then for metastatic disease, again, to the lung, this is an example of a difficult to find pancreatic metastases that this technology was able to help us find with a great deal of confidence to make sure we're getting it out. And just as a last, I know this is about lung cancer, but we're looking at these types of technologies in many different areas and diseases. And thoracic surgeons and many of the docs here touch other types of diseases other than lung cancer. This is the first use of this type of technology, and now esophageal cancer. But for the lung, we use it quite a bit, and it is certainly helping us to do, I think, a better job. So really just highlighting one of the areas in thoracic surgery that we are leveraging new technologies, constantly investigating to see how we can do a better job for the future and for our patients. So I believe that these types of investigations, again, help us to do a better job at surgery, combined with some of the other things you're going to hear about on the talks today, collectively help to escalate and elevate the treatment of lung cancer. And many of these investigations have been done right here at UT Southwestern. So I'm going to end with that. And certainly, again, at the end, happy to take questions. And just a small, really view of the overall scope of work that's being done here at this institution. Thank you.
Excellent. Thank you, Dr. Sakaria. Next up, we have Dr. Stephen Wu. He's an assistant professor in the Department of Internal Medicine here at UT Southwestern and a member of our interventional pulmonology team. So, Dr. Wu.
Great. Nice to meet you all. Today I'm going to talk about interventional pulmonology and its role in lung cancer and pulmonary nodules. Interventional pulmonology is a subspecialty of pulmonary medicine that focuses on minimally invasive diagnostic and therapeutic procedures for diseases in the chest. Rather than open surgery, we use advanced bronchoscopy and pleural techniques to both diagnose and treat patients, especially those with lung cancer and pulmonary nodules. On the diagnostic side, we perform intrbronchial ultrasound or EBUS, which allows sampling the lymph node for staging of lung cancer. We also use robotic navigation bronchoscopy to reach very small or peripheral lung nodules that would otherwise require surgery for diagnosis. From a therapeutic standpoint, interventional pulmonologists manage airway obstruction caused by lung cancer. Using flexible bronchoscopy tools, we can debulk tumors, place airway stents, and apply thermal or cryotherapy to restore breathing and improve quality of life. Finally, we also handle pleural disease, particularly malignant pleural effusions related to lung cancer. These patients often benefit from procedures such as thoracentesis, which is a drainage of fluid in your lungs, or placement of tunnel pleural catheters, which allows drainage on an outpatient setting and allows for symptom control. In summary, interventional pulmonology combines cutting-edge technology with minimally invasive techniques to improve both diagnosis and palliation for patients with thoracic malignancies. And the next one, today I'm going to talk about the robotic-assisted bronchoscopy, which represents one of the most significant advancements in minimally invasive diagnosis for lung nodules. Traditional bronchoscopy is limited in its ability to reach small or peripheral nodules, especially those located beyond the visible airway. The robotic bronchoscopy platform was developed to overcome these limitations. We have been using robotic bronchoscopy since 2020 here at UT Southwestern, and since then it has become an essential part of our diagnostic procedure for evaluation of indeterminate lung nodules. This platform combines robotic precision and stability with 3D navigation and real-time confirmation using CT scan as well as ultrasound. The robotic catheter's ability to articulate and hold its position allows us to navigate deep into the lung with accuracy that is difficult to achieve manually. One of the key advantages is that it addresses the limitation of conventional bronchoscopy, specifically the difficulty accessing small or peripheral lesions. By maintaining precise control and visualization, we're able to obtain diagnostic tissue while minimizing the trauma to the surrounding lung tissue. As a result, diagnostic yield is significantly improved, particularly for small or subsolid nodules, and the risk of pneumothorax or other complication is much lower than the transthoracic approach. In summary, the robotic bronchoscopy has transformed how we approach lung nodule evaluation, offering a safer, more accurate, and minimally invasive pathway to early diagnosis, which is critical in the management of lung cancers. The robotic assisted bronchoscopy is not only transforming how we diagnose lung nodules, but it's also rapidly expanding into the realm of the therapeutics. Initially designed for precise navigation and tissue sampling, the same platform is now being leveraged for a variety of advanced interventional procedure within the lung. One such example is a transbronchial cryobiopsy, which allows us to obtain a larger, higher quality tissue sample using freezing techniques. This is compared to traditional forceps biopsies. This improved diagnostic accuracy, particularly in cases like interstitial lung disease or inflammation in your lungs, or when the molecular profiling for lung cancer is needed for cancer management. Another major application is fiducial marker placement to guide surgical resection. Using robotic platform precision, we can place the marker exactly where it's needed, even in deep or peripheral lung lesions. We also use ICG diazo coils or direct dye marking to help our surgical colleagues to localize small or subsolid nodules during minimally invasive resections, improving intraoperative accuracy. Looking toward the future, the robotic bronchoscopy is evolving from a purely diagnostic to more therapeutic. Emerging work is focusing on intrapulmonary ablations. This includes thermal ablations as well as pulse electric field ablation as potentially minimal invasive treatment options for the future considerations. In essence, what began as a tool for diagnosis is quickly becoming a platform for comprehensive therapy. We're trying to bridge the gap between pulmonology, thoracic surgery, and oncology to offer patients more targeted and less invasive options. The last thing I want to go over is endobronchial ultrasound that we do. Endobronchial ultrasound, or EBUS, is a cornerstone of a minimally invasive mediastinal staging in lung cancer. This allows us to directly sample lymph nodes in the chest without the need for surgical mediastinoscopy. Using real-time ultrasound guidance, we can visualize the lymph node structures and precisely guide the needle into the target area for tissue acquisition. The EBUS has an excellent diagnostic yield and a very strong safety profile, making it a preferred first-line approach to evaluate mediastinal and hilar lymphadenopathy, which is a swelling of your lymph node in the middle of your chest. One of the major strengths is that it provides real-time direct visualization. So rather than sampling blindly, we can see the needle enter the target and confirm the adequate sampling on the spot. What's especially exciting about how EBUS integrates to newer technology is that it can be performed in the same session as the robotic assisted bronchoscopy that I spoke about before. This combined approach allows comprehensive evaluation for both primary lung lesion and mediastinal staging in a single anesthetic event, streamlining diagnosis and reducing patients' risk. Additionally, EBUS can be paired with advanced tissue acquisition methods, such as cryobiopsy. This allows us to obtain a bigger and higher quality specimen from the lymph node themselves when needed for molecular testing or for more difficult diagnosis, such as lymphoma evaluation. In summary, the EBUS exemplifies how minimally invasive techniques can maintain high diagnostic accuracy, improve efficiency, and enhance patient safety. And that's all I have for interventional pulmonology on lung cancer and lung nodules. Thank you, everyone, for your time.
Thank you, Dr. Wu. Next up, we have Dr. Sheena Bala. She is an assistant professor in the Department of Internal Medicine and a member of our medical oncology team. Dr. Bala?
Can you see my screen okay?
Yes.
Okay, give me 1 second and just, okay, all right. So thank you so much for inviting me to be part of this panel. In the next 7 to 10 minutes, I'm going to talk a little bit on immunotherapy and targeted therapy. Um, we're going to talk about what these agents are, what are the advantages, who qualifies. So immunotherapy was initially approved for lung cancer actually over a decade ago. And this started with the approval of nivolumab in May of 2015 for patients with pre-treated non-small cell lung cancer. And so since then, there have been numerous clinical trials that have made immunotherapy standard of care for both early stage and late stage disease in both non-small cell and small cell lung cancer. Immunotherapy uses our immune system to attack cancer cells. And before I get into some of the details, I want to clarify that immunotherapy is a broad term. It may include immune checkpoint inhibitors, which is what's currently approved for lung cancer, and that's what I'll focus my discussion on today. But this could also include cancer vaccines, adaptive T cells, and other strategies harnessing the immune system. There are quite a few immune checkpoint inhibitors that are approved in lung cancer, as you can see here. And the one that your doctor may prescribe would depend on the stage of your lung cancer as well as the type of lung cancer. Our immune system is actually quite important in the anti-cancer response. So cells of our immune system recognize cancer cells as abnormal and then kill them. And so as you can see in this diagram, tumor cells release something called tumor antigen. So these are markers on tumor cells. And ultimately our T cells, which is an important component of our own immune system, um, find these tumor antigens and find tumor cells expressing these antigens to kill them. Well, cancer learns to kind of figure a way around this, and they use immune checkpoint pathways to decrease our immune response. So, on the surface of a cancer cell, and that's this circle agent in yellow, we have proteins, including a protein called PDL1, that essentially puts the brakes on the immune system. So, when a T cell, which is here in purple, encounters PDL1 on a cancer cell, it's basically tricked into signaling down our immune system. And so what immune checkpoint inhibitors do is they take off these brakes. So they prevent these checkpoints, such as PD1, PDL1, from connecting so that our immune system does not slow down and our T cells continue to attack the antigens and the cancer cells. So the main advantage of immunotherapy is some patients will really experience long-lasting benefits. The responses to immune checkpoint inhibitors can often be seen within the first 6 to 8 weeks of starting treatment. And some patients will really have durable responses, sometimes even off of therapy. And so this is an example of a patient of mine who was actually initially diagnosed with metastatic non-small cell back in 2021. And you can see the tumor in his right lung, which was about 5.5 centimeters at the time, decreased over 50% within a couple months of starting treatment. And 2 years later, he had residual disease, has had a long-term response to pembrolizumab since this time. For non-small cell lung cancer, biomarkers can help us identify which patients may benefit the most from immunotherapy. And so a simple definition for biomarkers would be proteins, genes, and other molecules that affect how cancer cells grow, die, and respond to other substances in the body. And so we know that certain biomarkers may actually predict a higher response to immunotherapy. So that's a protein called PDL1, like I just talked about. Versus others actually may predict a lower response to immunotherapy, and that's a mutation called EGFR, which I'll reference a little bit later. And so your oncologist would be sending these biomarkers to help guide treatment decisions. The last thing I wanted to say about immunotherapy is as anything, there are side effects, and it's really important to have clinician and patient education and continuous attention during your course of treatment. These side effects are typically related to overactive immune system. They can affect any organ, and they can occur weeks to months after starting treatment. But actually, most patients do not experience serious side effects with immunotherapy. For most patients, they actually do quite well on this type of treatment. One of the big contraindications would be if you have a significant active autoimmune disease that requires active immunosuppression. Based on kind of this specific case, that might be a reason that you wouldn't be a good candidate for immunotherapy. If you were to develop side effects, the treatment would depend on the severity, so it might require holding or discontinuing therapy or using steroids or immunosuppression to calm the immune system. And this is something as an oncology team, we're very trained to look out for and treat. Moving on to targeted therapy. So we know that a subset of patients with lung cancer, specifically non-small cell lung cancer, will have driver mutations and respond to targeted therapies. So these are oral or IV drugs that target genes and proteins that can help cancer cells survive and grow. And so these colored boxes actually show the numerous targeted therapies that are approved for non-small cell lung cancer. And so, how do you know if you're a candidate for targeted therapy? Well, you have comprehensive biomarker or molecular testing. This testing can be done on biopsy or surgical tissue or on blood, and that's referred to as a liquid biopsy. At UT Southwestern, it's our standard practice to send next generation sequencing or NGS testing on the tissue and often on the blood as well, where we can look at a large number of tumor genes at the same time to figure out, how our patients may benefit from targeted agents. And so in selected populations, targeted therapy can be quite effective. So this is an example of one targeted agent. So EGFR is a common targetable alteration in lung cancer. It's seen in about 15 to 20% of patients with non-small cell, and about actually 40% of patients who develop lung cancer who are never smokers. And with these agents, we can see robust responses within weeks. And for these patients, EGFR targeted therapy is actually more effective than chemotherapy or immunotherapy. This is an example of a patient of mine who had metastatic EGFR lung cancer. And within 8 weeks of starting an EGFR inhibitor, you can see that the large tumor in her left lung, as well as the pleura or the lining of her lung, had a significant reduction in size. And she also had a remarkable improvement in her clinical symptoms. The toxicities of these agents are really going to vary agent by agent. For example, for EGFR inhibitors, the most common toxicity would be rash. And again, something that your oncology team would be very trained to look out for and treat. At UT Southwestern, we have a lot of ongoing clinical trials. We have over 20 actively recruiting studies in phase 1 to 3 for patients with lung cancer that are looking at immunotherapies, targeted therapies, as well as other novel strategies. And so I would encourage all patients and caretakers to consider clinical trials as a potential treatment option as they give access to new or promising therapies in all stages of lung cancer. And so in summary, just a couple points. So the long-term outcomes for patients with lung cancer has really improved over the past decade. And this is driven largely by our advances in immunotherapy and targeted therapies. Biomarker testing is really important to guide personalized treatment across many types of lung cancer. And here at UT Southwestern, we have ongoing trials and multidisciplinary collaborations to continue to refine the treatment strategies for patients with lung cancer. Thank you so much for your time. I'm happy to answer any questions during the Q&A.
Thank you, Dr. Bala. Next up, we have Dr. Kenneth Westover. Dr. Westover is a professor in radiation oncology here at UT Southwestern, and also serves as the chief of lung radiation oncology services, a part of our cancer services team. Dr. Westover.
All right, thank you. Can you see?
Not yet.
Oh, oops, there we go. All right.
Perfect.
All right. It's an honor to be part of this this group, and I'm glad to speak to patients about radiation oncology. So I'm a radiation oncologist. And I just wanted to give sort of an overview of some of the major techniques that we have access to nowadays for treating lung nodules that are not surgically approachable. So many patients have medical problems that prevent them from going to surgery. And so in those situations, and these can be things like lung disease or heart disease, in those cases, there are great options. And I just wanted to highlight what those are from a radiation oncology perspective. One of the main techniques that we use is called SBRT or SABR. And this is an ablative radiation technique that really was pioneered in large part in the United States, at least by leaders in the UT Southwestern community. So this treatment it involves 3 to 5 treatments typically that can be spaced out by days, and actually we've been even using longer time periods to allow for tumor shrinkage between treatments. And this is high dose per fraction, and it's very well tolerated. Sometimes people refer to this as radiosurgery as well. This technique is very effective. It approaches the efficacy of surgical treatment actually with 90 to 95% tumor control rates at 5 years. You might ask, well, if this is the case, why wouldn't you always do this? And the reason is that there are a number of advantages to surgery, making it really the standard of care. So we always think about surgery first for dealing with a lung nodule. But if that's not an option, radiation therapy, radiosurgery is an excellent option. I like this slide. This is from a paper that came out last year, just showing quality of life differences when you compare surgery versus radiation. And the reason I'm showing it is just to kind of give you an idea that these radiosurgery techniques don't impact quality of life really in any significant way. So the blue curve here is for radiation therapy. And so patients do very well, even patients with significant medical problems. UT Southwestern, because of its role in the national trials that established SABR, has provided education to the rest of the country and even the world. And we have an education program that's been going for at least a decade, where we've trained over 1,000 providers how to do these techniques. And in fact, when I was in residency training, the institution where I was sent their people to UT Southwestern to learn how to do this. So we have a very long history with a very deep experience at all levels in the care team. So, one of the newer things that we're doing is adaptive radiotherapy. So this is probably 2 years old now that we've been thinking about adaptive treatments, and this was enabled in large part by AI technologies that have come about that enable us to go through very rapid treatment planning cycles. So whereas treatment planning typically takes us around 3 to 5 business days, of all kinds of behind the scenes work, these systems allow us to do that replanning within minutes. So we do it while the patient is laying on the table. We can make adjustments. We use various types of imaging to enable this. So we have at UT Southwestern invested a lot into obtaining CT-guided, MRI-guided, and PET-guided adaptive machines. So we have multiple of all of these, but the PET, we just have one of the PET. But the CT-guided, that allows us to use a CT scan, which is quite good in terms of image quality, to make adjustments in real time to a radiation plan while a patient is laying there on the table. Usually takes about 15 minutes to do that. MRI-guided treatment provides even better imaging in some cases, depending on what we're looking at. And that takes slightly longer, but still around 20 minutes or so to do the adjustments on the day of treatment. And then PET-guided, this one, is also fairly fast in terms of its replanning capabilities. But the special thing here is that it actually uses the PET signal in real time as the treatment is being delivered to change the plan as the patient is breathing. So it has a special role in terms of looking at respiratory motion. So what this slide kind of illustrates what I'm talking about, why adapt. These are 2 patients that we treated here, where we're comparing the initial treatment on the left to the maximum response on the right. And you can see that the tumor has decreased in size significantly between the start of treatment and the maximum response. And so when this happens, it allows you to, if you adjust the plan, reduce the radiation dose to other sensitive organs like the heart or esophagus or chest wall. And so this is the reason to do it. You can adjust the plan. As part of this, just to highlight some of the innovation at UT Southwestern, part of this effort to do adaptive treatments, we've had to come up with even new ways of patient positioning. And so this is one of the devices that came out of UT Southwestern that I've been involved with, that uses a radiolucent frame that's basically invisible to X-rays, so that you don't have to concern yourself. So that we don't have to concern ourselves with attenuation that comes from the frame. So this is the type of responses that we see across various tumor types. So you can see on the right-hand side various non-small cell lung cancers as well as small cell lung cancers that all show variable responses. Not everybody responds in the same way, but many patients do have shrinkage over time. And just on the left-hand side, I'm showing a patient that had a tremendous response on radiation therapy. By week 3, tumor had essentially regressed to non-visible. One of the other things that our experience with adaptive radiation therapy has led us to do is to think about the parameter of time. So typically, SABR is done on an every other day kind of, or twice a week kind of a basis. So, it's fairly limited time in between treatments. But we've now begun to think more deeply about spacing that out. And what this does is it gives time for the tumor to shrink, and it also gives time for the immune system to become involved. And so one of the common spacings that we've been investigating is a 3-week pause between treatments. And this is, to be clear, this is really highly investigational at this point, but we've seen some promising results that make us want to continue looking at this, especially in patients with high risk disease where we're next to very sensitive organs, again, like the heart, the esophagus, allowing those tissues to heal in between sessions, and patients with other reasons like pulmonary disease. So, just to highlight one of the trials that we have open in this space, we started an MRI guided adaptive therapy trial, and this one looks at patients specifically with very central tumors. We know that the airway in particular is very sensitive to radiation, and if you overdose that, it can lead to really catastrophic problems. The esophagus is similarly sensitive, so these central tumors are very tricky sometimes to treat. So, but with MRI, because it gives us much better visualization, you can see in the bottom right-hand corner the image that the MRI gives us, and that's a real-time image in a treatment situation. We can see the image, we can see the tumor very brightly, and you can also see the esophagus right here, right above it, right abutting the tumor. This allows us to see very clearly the esophagus, the airway, the tumor, and make fine adjustments using the MRI imaging on the day of treatment. This is important because it allows us to shrink the margins. Dr. Sicario talked about margins for surgery. They're trying to get big margins. They're trying to cut away, additional tissue so there's no tumor left behind. In our case, we're trying to keep the margins small so we don't treat into normal tissue that would be sensitive. So the MRI guidance really allows us to spare those normal tissues. And so this trial is looking at reducing those margins and using the MRI to track the tumor motion in real time. So those are just some of the, I think, high points around lung nodules that I wanted to talk about with the radiation therapy.
Thank you, Dr. Westover. So for the remaining portion of our time today, we're going to answer, I have Q&A for the panel here today. And just a reminder, all of this information, the presentations, the webinar will be sent at a later time this week. And so if you have any follow-up questions, please feel free to reach out and we will make sure to take care. The first one I actually am going to ask Dr. Westover, just on you talked about obviously the treatment options for radiation truly in oncology. How would you determine? We've had a question about if that is a best option or if they should be considered for surgery. How do you decide and how do you work with the team here to really create a treatment plan?
Yeah, I mean, the starting point is just to acknowledge that surgery is the standard of care for early stage lung cancer. And so it's really a process of exclusion. I really rely on our expert surgeons who are fantastic, just really well trained and just excellent in all regards. I depend on them to tell me whether or not the patient is a surgical candidate or not. Patient preference also does matter. Some people don't want to go through a surgery. And so that also factors in. But those are the kind of things that we think about. One other thing to mention is that with lung nodules, by Dr. Wu's team is incredible as well about getting biopsies, but sometimes a patient is high risk for even biopsy. And so in those cases where we have the imaging that looks like lung cancer, there is space for empiric treatment with radiation. And we do that quite often, but it's only after the multidisciplinary discussion that Dr. Sakaria talked about.
Absolutely. Absolutely. Thank you. Next question I'm going to ask is for Dr. Wu. How do you determine if a lung nodule is cancerous or has the potential to turn into cancer?
We have multiple ways to determine that, but usually if the nodule looks concerning on a CT scan, we biopsy with a robotic assisted bronchoscopy for tissue acquisition, and we have pathologists give us a final diagnosis whether this is a malignant nodule or a benign nodule.
My next question is going to be for Dr. Bala. There's been a lot of questions and interest around our clinical trials. So could you expand on how a patient could potentially be enrolled in one of our trials? And the second part of that, if there's any trials related to lung cancer vaccines or new options in that space?
Sure. So if a patient were interested in clinical trial options, um, they would make an appointment, and as medical oncologists, we'd be happy to be the first place that they would start, and our clinical trial team would screen them for potential studies. And then we would meet and talk about what the trial looks like, what the procedures are, expectations, and then there's a very formalized process to get a patient on trial, screened, and proceed with treatment. In terms of cancer vaccines, so essentially the idea there is utilizing the unique antigens or neoantigens that lung cancer cells might express, and then using our immune system to target those antigens. Right now, there's no approved vaccine for lung cancer. We do have a lot of trials in that space, in general, but also at UT Southwestern. One that comes to mind is in the adjuvant setting. So after surgery, we do have a trial that uses immune checkpoint inhibitors in cancer vaccine. So I think it's such a personalized approach. It's hard for me to speak towards everything. I would just encourage, if you're wondering about trials, to speak to your medical oncologist about it.
Thank you. My next question is for Dr. Sakaria. Obviously, you and I have an opportunity to work very closely together, and there's been a lot of advancement in robotic surgery and potential options for patients to have robotic surgery a part of their lung cancer treatment plan. Could you just expand a little bit on what that looks like today and how you incorporate that into your practice?
Sure. I think, you have to take a step back from that because there's a lot of glamour around this that comes out in the public about any technology that is applied to these. And it's important to couch that a little bit because the robotics, whether it's some of the imaging technology I showed, some of the advances in vaccines or what have you, it's important to understand these are all trials that have made us understand where the value for any new technology that comes in should be applied, can be applied. And there's a lot of consideration to that. I see this stream of questions coming up on the webinar. Just to let the people out there know we see them. We cannot answer all these questions, and the intent is not to get sort of personal advice on this webinar. But you're always welcome to call in and see if there's an evaluation that needs to be done. Regardless, robotics, the first thing I tell patients is beyond robotics, beyond the approach, the right cancer treatment, the right operation, the right treatment overall is by far the most important thing. And you don't necessarily want to come into an appointment with a presupposition of what you want or what you think is the best. Really rely on the information that you get from the experts and the docs. And that's why this panel and this particular forum and approach to how we treat our patients is so critical. Dr. Westover is an international champion and expert in radiation oncology. Same for every person on this call, Dr. Paul, everybody. Dr. Wu's group is the top utilizer of the ION platform in the country, at least for multiple years going ahead. So, these are experts who are, I think, to some degree, understanding, again, could probably treat a lot of things that you may not see out there in the public. But when it comes to robotics, I guess kind of put that out there in the background, that robotics is an outstanding approach for minimally invasive surgery. I've been doing it for over 15, 20 years now. And it allows us to approach very complex operations in minimally invasive ways in the right setting for the right patients. And that's the most important thing. But it does allow us to get people back to work sooner, allow us to minimize pain, along with other sort of innovative ways we're looking to minimize pain. But most important is, are you getting the right operation and are you getting the right treatment for the particular disease you have? And it's not a blanket statement for any individual. It's an individual treatment plan for every person that involves every person on this call.
Thank you, Dr. Scaria. There's a few questions in the chat that I will answer related to access and when we can expect to have an appointment here at UT Southwestern. That may vary by each of these various groups and specialties that we have on the call, but absolutely at UT Southwestern, we are committed to really ensuring that our patients are treated effectively and timely. I can speak for everyone on this call that each of the providers here are absolutely committed to treating timely patients and getting the information, whether it's a member of any of these members of this team. And that varies for our partners as well. There's a question around Parkland and some of our other partners. We're absolutely committed to working with them and ensuring the pathway is easy and something that is very timely as well. A question for the panel, and this is maybe for everybody. There's been some questions around screening. When should patients start to be screened for lung cancer if they have a prior history potentially of smoking, non-smoking? What does that look like, and what is your opinion on when patients should start to look into that?
Sorry, Karen, who was the question for?
It could be for any we'll start with you, Dr. Scaria.
Oh, for lung cancer screening?
Yes, sir. When should patients,
yep,
start to explore that option?
Well, I see that Dr. Westover actually just posted something on that, the lung cancer screening guidelines. There are specific guidelines by our national societies that specify who qualifies for lung cancer screening. And I would suggest that anyone who's got a smoking history and is above the age of 50 or so should probably just speak to their primary doctor about whether they qualify for lung cancer screening. Those are really the criteria. And there are specifics around that, but I think it's worth a specific discussion with your doctor. We know that lung cancer screening has significant upswing and has decreased the mortality from lung cancer in the US, but there is ample room to improve our rates of lung cancer screening. And that's where we struggle the most now, just getting the right people to those screening CAT scans. We are actively decreasing those barriers here. So I think that's something to explore as well. Interested to hear others from the group as well.
Yeah, I reposted the guidelines. These are the NCCN guidelines that we develop. That this will answer some of your questions about when do you do something about a nodule? At what size do I get worried? These are the guidelines that kind of are meant to direct. And so currently the guidelines are over the age of 50 and more than 20 pack years of smoking history earns you a low dose screening CT for lung screening.
Thank you. My next question is for Dr. Wu. Specific to lung nodules, some patients have asked, do they ever disappear? Do they reoccur? And if they do reoccur, how often does that actually happen?
Great question. So the nodules can disappear. It really depends on the etiology, such as if it's inflammation or infection, they tend to disappear. If they disappear, usually that's not a lung cancer malignancy. So it's really a good news if your lung nodule can disappear. The recurrence rate, I cannot really speak to that. I don't really know if there's any data to it. I had to get back to you on that.
Thank you. My next question is for Dr. Bala. Dr. Bala, we've had many patients describe their kind of healthcare journey in our chat. I'm not getting into much of specifics, but backgrounds such as other complications with potential cardiovascular or neurological aspects of their care how do you take that into consideration when treating these patients? Should everyone call their oncologist no matter what, or is there different pathways we should direct those patients to?
And maybe I'll speak to some of the comments or questions I saw asking specifically about patients who have autoimmune um, complications, such as a transplant history or other kind of disorders along those lines. So, for immunotherapy, like I had mentioned, when we're proceeding in somebody with an autoimmune history or with a history of a being on immunosuppression, we have to be very cautious. And there are certain autoimmune conditions that we do have a lot of comfort giving immunotherapy. And an example would be rheumatoid arthritis. We have over and over been able to successfully give immunotherapy to those patients, but with very kind of a lot of consideration and communication with a rheumatologist in case we run into issues. Because about if we give immunotherapy to somebody with rheumatoid arthritis, probably 30 to 50% of the time we're going to flare up their RA. However, if somebody has a history of a solid organ transplant, that is almost a contraindication at this time. There are clinical trials looking at, for example, giving immune checkpoint inhibitors to patients with a kidney transplant. And that is, we don't have one here at UT Southwestern yet, but that's something under study. But again, I think this is a very, like, it's a multidisciplinary discussion. So we've been talking here about our group, but if I was to take care of a patient with another comorbidity, whether it's cardiac, pulmonary, etc., I would be in very close contact with their doctors.
Thank you. And this question is for kind of Dr. Wu and Dr. Sakaria. The question is, how often should a patient be reevaluated? If they have a nodule, how often should it be checked on, scanned? And is there a particular size of nodule that is more concerning than others?
I would say, and I'd like to hear what Dr. Wu has to say. Yeah, there are guidelines and recommendations, but I would stress again, there are broad guidelines and recommendations that are meant to cover the population, right? For any individual nodule or person that really warrants a set of eyes, Dr. Wu, myself, others like us, looking at it and then making a decision about it. But there are guidelines, just like the others. I think Dr. Wu posted some of those, 8 millimeters. But again, I don't know. I have to see many aspects. How many nodules? What do they look like? What do they look like on CAT scan? And what is their progression, importantly, over time? And what's the history of that particular individual? Someone had a question there about how many benign lung nodules are there out there. I just give the rough estimate, and maybe Dr. Wu, you can chime in. I'd say if we took a random sample of people off the street and did 100 CAT scans on them, about 50 of them are going to have a lung nodule. Maybe one will be cancer. So that's sort of the scope of what we look at in the broad population. So it's also important to understand a lung nodule by no means equals cancer, but we have to do our diligence to identify the ones that might be cancer, because that's probably where the highest risk is. Steve, that's how I would sort of approach it in my practice, and we see thousands of nodules over our career.
Definitely, I agree with Dr. Sakaria. The nodule really depends on the size and your risk factor. And so that's how we really determine when should we rescan or reevaluate with whether these nodules has grown or shrunk or stayed the same. So really is individualized to the care. So please talk to your provider and have an extra set of eyes to determine what's the best evaluation for these lung nodules.
And there was a question that I'm happy to answer around AI and the use of lung cancer treatment. And absolutely, UT Southwestern is on the journey of adopting artificial intelligence to be able to review patients' images, to be able to identify if there's a potential nodule or finding, and really have that routed to the care team for them to evaluate, to contact the patients. So we are actively adapting AI into this practice as well. We are at time, but I wanted to ensure that the panel, if there's any final thoughts or speaking points that we did not cover today for the panel. Did anyone have any last minute items? All right. Dr. Scaria.
I would just say there's a lot of questions here about access. We may just want to show that number again. And to let you know that we do our best to get patients in very quickly, as best we can, because the time to treat, if something's a lung cancer, is important, and there's a tremendous amount of effort and resource that goes into getting patients into the system that need to get here.
Well, we greatly appreciate this opportunity to speak with you all today. We will be following up with more information virtually. And yes, please, I will share the number here once more in the chat to reach out. And you're not on this journey alone. We are here to help. Every member of this team will support you on this journey, whether it's through patient care or just additional information. So thank you all very much, and we look forward to talking again soon.